Welcome to today's online conversation with fertility experts Dr. Georgiana Hyman of Jerusalem and Dr. Raelia Liu of Melbourne, Australia. Our topic today is infertility and egg freezing, the treatment options in Israel and Australia. My name is Miriam Pakanowski, and this session is a health promotion activity of the Australian Friends of Shaarei Tzedek. We are so excited to bring to you what we believe will be a most informative and fascinating conversation. The Australian Friends of Shaarei Tzedek is committed to supporting Jerusalem's most central hospital, Shaarei Tzedek. 22,000 babies are born across its two campuses every year, and the hospital is committed to the healthy future of Israel. We support programs and projects at Shaarei Tzedek, and we're proud to be a health promotion charity in Australia, sharing the miracle of Shaarei Tzedek with the Australian community. We are so honoured today to be hosting Dr. Geordie Hyman, who is touring Australia, together with Dr. Naomi Grummet of the Eden Centre. A few words about both of our speakers, both Dr. Raelia Liu and Dr. Georgiana Hyman. Georgiana Hyman was born in Melbourne, Australia, and is a graduate of Monash University in Melbourne, Australia. She completed her Obgyn residency at Shaarei Tzedek Medical Centre at Jerusalem, and she went on to fulfil a 2-year fellowship in reproductive endocrinology and infertility at McGill University, Canada in 2013. She has been working intensely in the field of IVF for over 10 years and is currently a senior staff specialist in Shaarei Tzedek's IVF unit, heading the fertility preservation and egg donor programs, as well as directing fertility clinics of Cloet Health Services in the Jerusalem region. That's just some of her many achievements. Dr. Raelia Liu will be familiar to some of our Australian audience. She is a CREI fertility specialist, gynecologist, and director of Women's Health Melbourne. Dr. Raelia also grew up in Melbourne and completed her medical degree at Monash University. She graduated with honours in 2004 and later trained as a gynecologist and obstetrician at Royal Prince Alfred Hospital in Sydney. She completed her Masters of Medicine and Reproductive Health Science and Human Genetics at the University of Sydney and a PhD in Preconception Health Promotion and Reproductive Genetics in 2016. She is passionate about preconception genetic carrier screening and applying IVF for the purposes of pre-implantation genetic diagnosis. She helps couples affected by or carrying the risk of genetic disease to have healthy babies. She believes that is one of the greatest miracles of IVF treatment. Thank you to both of you for joining us today. Thank you also to the Australian Friends of Shaarei Tzedek board member, Helen Brustman, OAM, for so graciously joining us and for thanking our speakers at the end of this speech. So without any further ado, thank you again. Let's talk. What actually happens when a couple what can a couple actually expect when they're having difficulties and when they first come to see you? Raelia, would you like to answer that first, please?
Sure. So I think really before we talk about infertility, we have to understand what normal fertility means and what a normal expectation of the time it takes to get pregnant is. So what we expect is that 80% of couples where there's not a problem will be pregnant within 6 months of trying, and 90% of couples where there's not a problem will be pregnant within a year of trying. So if a couple have been trying for more than a year without having had a pregnancy, it's time to have a close look at why. Sometimes we investigate after 6 months if there's a risk factor for infertility, such as advanced age, where the woman is over 35 years. And that's really the definition from a medical perspective of advanced maternal age, because that's around the age where egg quality starts to decline naturally and makes it a little bit more difficult to help a couple if they're facing barriers for other reasons. So we sometimes escalate to assistance a little bit faster in that instance. There are some women and couples who need intervention more immediately, and that's, for example, when there's no ovulation, when somebody's not having a regular cycle and has no chance of getting pregnant without releasing an egg, or when there's a known underlying concern such as a genetic condition where assisted reproduction is an option that a couple might want to learn more about. So usually when I address a couple who have come to me with a concern that they have a delayed conception, I usually do a thorough investigation of both male and female in the context of a heterosexual couple, because at least 50% of couples who do struggle will have some degree of male factor infertility. So a lot of preconceptions around fertility is that it's a female issue, but not always. So really imperative to investigate holistically both the male and the female, and have a look into what barriers might there be that's contributing to infertility. So usually when I first meet a couple, I talk to them about investigations and hopefully arrange investigations to help me more thoroughly understand their situation, take a detailed fertility history, and then briefly outline all of the options available to them. And subsequently, it will become clear which options are more appropriate for them as an individual couple to optimize their chance of having a baby. And also, things might be, or treatments might be chosen based on their wishes and worldview, if there are multiple options. So we might choose a first-line treatment that sits more comfortably with their beliefs, or sits more comfortably with their philosophy of how they would like to proceed.
Thank you, Aurelia. That's a great overview. Georgiana, I would be really interested in your perspective of how that compares when people come to you at Shareathetic.
So I would say I'm pretty much on par with exactly what Rayleigh is saying about the general approach to fertility, and I would agree that I don't want to assess, or I don't recommend being assessed before around the 1 year mark, unless there's something really obvious in the couple's history that would point us towards intervening earlier. And I think that that's something really important as well, that couples shouldn't be too stressed in the beginning when they're starting out and trying to have a family, because as you said, most of them will actually get pregnant spontaneously. And when they do come for assessment, I think one of the differences between the Israeli health system and what you have in Australia is that in Israel, IVF is basically a separate treatment and unit. So in Shareathetic, we're treating all the couples that have not gotten pregnant yet through all the other sort of fertility options, be it hormonal stimulation or intrauterine inseminations or a combination. We kind of separate in Israel the actual in vitro fertilization, which requires the hospital and the lab and involves egg collection and fertilization in the lab. And any treatment up until that actually happens in the community, in, I guess, the Medicare equivalent or the Kupat Cholim. So my work is kind of separate in that I have my IVF work, where we see the couples that are coming that require IVF, which may be those that have gone through conventional fertility treatment and not achieved pregnancy, or couples, let's say, that have a known genetic disorder and they want to do pre-implantation genetic diagnosis to prevent that mutation being passed on and to ensure having a healthy child, or people wanting to or needing fertility preservation or very severe male factor infertility. So some couples do come straight to IVF, but the others we treat sort of more in the community. So I see a mixture of them because I also do have work in the community, but my general approach is that if couples come before a year, I offer reassurance. I do take a bit of a history to make sure there are no red flags that require investigation, but I would generally say, come and see me after you've been trying for a year, and then recommend a workup, as you said, both of the male and female partner. And I agree that there's this sort of misconception that fertility is a female problem, and it's not going to be the man, it's going to be the woman. And there can also be a lot of associations of sort of blame and guilt within the couple. And I think it's really important. The language I use is that this is, our problem, or your problem as a couple. It's not she has this, he has this, but let's send both of you for tests and see what comes back and see what treatment options we can suggest. The other thing I'd like to point out is that in Israel, IVF or any fertility treatment is actually funded under the healthcare system up to 2 children. So any couple, actually any woman who has not yet had 2 children is basically qualifies for fertility treatment, whatever that takes. So if she can get pregnant with, gentle hormonal stimulation and inseminations, great. And if not, up until IVF is funded but by the healthcare system, which I think is amazing. However, that then imposes on us as the treating team a certain protocol that we have to go through. So I can't just say these are all your options and let's pick what would be the best option. I basically have to offer the more gentle fertility treatments before we get to IVF. So sometimes I have couples come and say, well, I just want to do IVF. Like, I want to go straight to IVF, and they're actually not eligible. So on the one hand, it's amazing that it's funded. And on the other hand, we are somewhat bound by the guidelines and by what the Kupat Holim protocol is. So it's a limitation, but I think also an amazing strength. And it means that a lot of couples do come for treatment and they're not necessarily bound by financial constraints. Once a couple has 2 children, depending on their level of insurance, there's usually some sort of co-payment. But even once a couple has 2 children, they can actually come back for further treatment, either partially funded by the health system or some sort of co-payment. But they often come back for more than 2 kids.
I understand from both of you that you recommend about a year until there's any form of intervention. But I'm wondering, is there an age where you would suggest a fertility workup?
Do you want to go ahead?
Sure. Look, I think that in my situation, I'm willing to work someone up if they want to be investigated, because I think infertility can cause a lot of stress, and sometimes having the knowledge that basic tests are normal can give someone the confidence to take the time it needs to pursue the route of a more natural conception. It also gives me an opportunity to do some preconception health workup in terms of pre-treatment education as well, making sure that all of the things we can do to optimize natural fertility are being are being implemented. So I really am very much non-prescriptive about that. In Australia, the official college guidelines are that if you are over 35 and you have had 6 months of delayed conception, that is the time where referral should be made for comprehensive workup. And if you are under 35, that number is 12 months. And for that underlying reason that I spoke of earlier, that it's one of those things as humans that we're not the most fertile species. And every time we try, even if you're 21, your chance of getting pregnant per month if we release 1 egg is about 1 in 5. And so cumulatively over several attempts, the pregnancy rate increases. And so some people just do need to give it a little bit of time. Sometimes when you have a cycle where you don't conceive, it doesn't mean that egg and sperm haven't got together and had a go. It just means that, not everything has gone exactly right to the point of an implantation and a pregnancy. So
Sure.
It's one of those situations where we can't see what's going on in the body. But having said that, if a woman or a couple are suffering significant anxiety with a delayed conception, or if there's a very obvious reason that conception is not happening, I'm happy to intervene immediately with at least basic investigations for their peace of mind.
Thank you. That's very interesting. I'm thinking in terms of what type of workup is required before you go to egg freezing or something quite as sort of involved as that. Maybe, Geordie, if you could answer that for us, please. What would you see as a timeline or the workup process?
So I think that this goes back actually to the previous question of when should a fertility workup take place, besides what we've mentioned about the 6 months if you're 35 plus or 12 months if you're younger. And often people will come to me with a young woman who's about to be engaged and say, oh, before she gets married, the family of the groom want to know, is she fertile? And that's a very sticky situation to be in, because I don't always want to do that kind of workup or give that kind of news. But in general, I am of the opinion that knowledge is power, and I want to empower women and couples to make the best decisions about their fertility. And I'm not sure that there is an age that's necessarily too young to find out about one's fertility. And I really think that knowing that at the moment the numbers are good and all the tests came out, great, and there's no obvious problem, it can often give that reassurance and allow couples to relax and continue trying with that peace of mind that there isn't a problem. So even though we would consider that after a certain amount of time, unexplained infertility if it persisted, knowing that there's no actual problem, which is going to be a lot of most couples, can actually just sort of give that reassurance and allow couples to let it go and be a bit more relaxed. And I think there is often a lot of anxiety involved around fertility. One of the interesting questions that's come up and that I think we want to discuss is, what is the approach to egg freezing, both in Israel and Australia? And in Israel, again, we do have a prescribed age that elective or planned egg freezing is allowed. So it's only authorized between the ages of 30 and 41. That means a young woman below the age of 30 is not actually eligible to choose to freeze her eggs, which is an option that's becoming more and more popular as we're seeing more and more women that are still single later on in life. And in general, I am very pro egg freezing for single women as a proactive option to help them bring children later on. I'm actually now treating a couple who are gearing up for their second. They've already got one baby who's 9 months old, and they've still got another 31 eggs that the woman froze at age 33. And they're now gearing up to try another round. And we have a charity the eggs of over 500 women who've frozen eggs. And I think when egg freezing began in Israel, at the beginning, it was like very taboo, very hush-hush. People didn't want to share with their friends that they were doing it or their family. A lot of people don't share at all. And over the years, there's been a lot more awareness raised about egg freezing as an option. And the age at which women are coming forth to do it is getting lower and lower, which is what we want to see medically. And I would say for any woman reaching the age of 30, given that in Israel, that's when they're eligible to start considering the process, it's a good time to do a fertility assessment at any rate, even if she's not actively trying to have a baby or in a relationship, but to consider, is egg freezing an option? And the three, an approach to a woman who's going to consider freezing eggs is different to the approach to a couple. But for a woman freezing her eggs or wanting to know about her fertility or her ovarian, what we call the ovarian reserve, or the function of the ovaries, and what we would, I guess, what we're trying to do is kind of extrapolate how the ovary is going to keep functioning over the next X amount of years. So that involves basically blood tests, like a bunch of hormonal blood tests that are usually done in the early stage of a woman's cycle. An additional blood test that could be done at any time called anti-Müllerian hormone, which gives us more specific information about the woman's ovarian age, if you call it, or biological, her real true biological clock, and an ultrasound that will give us an indication of the number of follicles or small eggs in potential that may grow to become mature eggs, which is essentially what we want to collect. So a woman interested in the process is usually referred for both blood tests and ultrasounds as part of the preparation, at least her assessment, so that we can also try, what's very important, I feel, is giving accurate information to the women about, is it worthwhile going through this process? What's the likelihood of success? You know, some women are going to get 30 eggs and some women are going to get 5 eggs. And I think that we need to give realistic expectations, because the number that we're able to retrieve also may indicate where her fertility is holding and how useful these eggs are going to be in the future. And besides that, there's also a workup, including a breast exam and serological blood tests and a bunch of other workup that we do for anyone undergoing treatment. But in terms of her assessment, I believe that that's the general workup, and I think that's similar to what you guys are doing in Melbourne.
That is so fascinating. Thank you, Geordie. I guess there's the medical aspect of it, there's the legislative aspect, and there's the cultural effect of you know, the context that you're operating in. And I find that especially fascinating. Raelia, I'm wondering what your thoughts are on what would be like the ideal number of eggs that you would be looking to freeze.
So it's very different person to person. If you are for example, under 35, and particularly if you're closer to 30, if you freeze 20 to 30 eggs, you'll have a 95% probability of having at least one baby from those eggs, statistically speaking. If you're 39, 40, you'd have to freeze a huge number of eggs to get anywhere near that probability of success. And a similar number of eggs might get you more like a 50-50 chance of having a baby. So it's really important to contextualize where your patient is at in life, how their ovary function. So those measures that Geordie was talking about, the AMH and the ultrasound, that doesn't tell us about their egg quality, but it does tell us how many eggs might be able to be collected in a single cycle for that person. Quite often patients ask me, well, what's average? And I say, it doesn't matter what average is, because if you're not average, you're not going to be able to collect the exact number of eggs that's the average of patients with a very small ovary and patients of a very large ovary. So let's work out where you're at, and let's try and get your personal best result through individualized care. At the end of the day, you can't stimulate a follicle to grow if it isn't there in the first place. So we have to work what a patient has, and individualization of care is about not necessarily, kind of squeezing blood from a stone, but getting the best possible result for that patient in that cycle and cumulatively over as many cycles as it takes to achieve their goal.
Fascinating. Thank you so much. I'm wondering whether you recommend egg freezing or embryo freezing and how the process compares. Who would like to? Rayleigh, would you like to give us the first?
Sure. Well, I guess it's really important to define, well, what is an egg and what is an embryo. So an egg is a single cell, and it could potentially make an embryo if fertilized with a sperm. But just like a skin cell or a blood cell, it's a cell from a woman's body, an amazing cell with amazing potential, but just a single cell. An embryo is the result of an egg and sperm uniting to make at first a single cell embryo called a zygote, but then that embryo, often in modern IVF, is cultured in the lab for up to a week. And during that week of development, there is a process of exponential cell growth. So it goes from being a single cell union of egg and sperm to, by the time we freeze an embryo as a blastocyst, it might have 200 to 250 cells. So it's a very different and incomparable entity to an egg. Obviously, you do need sperm to make an embryo. So if you're single and you don't want to fertilize your eggs because you might be wanting to have them later fertilized with a partner's sperm, then making embryos is not an option for you. If you're a family and you're trying to have a baby, or if you're a woman who's trying to conceive with donor sperm, then making embryos could be a good option for you. And there are different advantages of embryos over eggs in terms of their survival from vitrification. So egg is a single cell. It's going to have either 100% or 0% survival. So we do lose some eggs to the freeze-warm process. So an egg is more vulnerable to being frozen and is more vulnerable to what we call cryo-injury than an embryo. An embryo is a little amazing ball of pluripotent stem cells, so embryonic stem cells. So an embryo can actually lose some of its cells in the freeze and warm process and compensate for that and recover and go on and thrive. So an embryo is stronger and more robust. It's also proven itself. So an embryo has gone on to develop over 5 days of development. So at least up until that very early stage, it's done everything right. And about 1 in 5 eggs will make an embryo that makes it to be a blastocyst. Not every egg will. So it's kind of incomparable. And I'd say how you choose between freezing eggs and freezing embryos is really based on your life circumstance and what you want to achieve, and also your beliefs and how you feel, because some people feel when they create embryos that they feel obliged to utilize them, whereas eggs, if you don't fertilize them, they can't make a baby, so a little bit less emotionally loaded.
How absolutely incredible. I mean, I'm absolutely loving hearing about your work. Jordana, I'm really interested in your perspective as well. And I would imagine that there'd be a lot of cultural influences as well on your work and how people make those decisions.
So it's definitely very loaded. And I think that's really accurate what you said about how people feel about a frozen embryo as opposed to a frozen egg, which doesn't seem to have the same amount of emotional, cultural significance. I mean, I was at a conference that was an ethics day workshop conference all about what is Israel doing about the hundreds and thousands of frozen embryos that basically, if a couple who goes through IVF then get pregnant but have additional surplus embryos, then we freeze them for future children. And a lot of them don't come back. And there was a policy that after 5 years, the couple can either come back to transfer the frozen embryo, or we can defrost them and destroy them. However, it's very tricky legally to defrost and destroy an embryo without the couple's written consent. And they've actually changed the whole consent form for frozen embryos. But until that goes through, we're left with hundreds and thousands of embryos sitting around different labs in Israel that have no use. And in Shaare Zedek, some of the embryos that are frozen are like more than 20 years old. And a lot of these couples aren't even aware that they have the embryos, but there can be a lot of emotional attachment to your embryo or potential baby. And also, the word embryo in Israel is a similar word that is used to a fetus. So it already seems to have a sort of status of almost being alive, and therefore defrosting and destroying an embryo doesn't sound great when it's translated in Hebrew, and there's a whole lot of cultural associations. So I agree that if we're talking about not using the eggs and then defrosting them and donating them or destroying them, there's a lot less significance that's attached to that. I think it's important for people to understand that once there is an embryo, particularly if we've grown to the blastocyst stage, we know a lot more about how we can predict how likely that embryo is to bring a child, because it's gone through the stages of fertilization and culture, and the only challenge it has is to survive the thaw. Whereas the eggs that we freeze will then have to survive the thawing process and be fertilized, and we don't know what the sperm of the future partner is going to be, and there's a lot more question marks. So when we have frozen embryos, we might feel a little bit more secure from a biological perspective. But I would agree that like the main issue at hand is the woman's beliefs and culture. What I will say is that I'm seeing more and more couples that actually get married a little later, and the rabbis are sending them to freeze embryos before they start a family. So couple gets married, age 36, the woman never froze eggs. The rabbi might say, before you guys even try, go straight and freeze embryos. And I've had more and more couples that are turning to that option. And then they say, well, should I freeze eggs as well? And I say, no, if you're married, like we've got the sperm, let's use it. And there's no real question for me, because it's better for them to freeze embryos with the husband's sperm, and we can rely on that. I have had 2 couples in the last 6 months who during the process of the workup actually got pregnant. So thank God they got pregnant very quickly, and hopefully they'll come back after the first baby, but that's a positive predictive factor in itself that they got pregnant so quickly. But there is more awareness, whereas egg freezing used to be something that single women do. Now more and more couples are actually thinking, well, this might be the amount of fertile years we may have. We want to have more than 1 or 2 babies. So before we even try, let's freeze some embryos for future children, and then we'll try naturally. So it's a little bit of a shift, as opposed to the IVF treatment or the fertility treatments which are funded. Fertility preservation in Israel is private, so it does cost out of pocket. So it may not be an option for all women or all couples. The other thing I do want to say is that there are some single women who, although they don't want to be a single mother, sometimes are choosing nowadays. And I would say these are more women in their late 30s. I said the upper age limit is 41, so maybe 38, 39, 40 kind of age, that are considering doing a split. So maybe freezing some eggs, freezing some fertilized eggs, even if it means donor sperm, which in itself is a huge loaded cultural religious question. But some women that we're seeing are requesting to do both, to essentially not freeze all their eggs in one basket and to leave themselves a few options. That said, it creates a very difficult situation. If, please God, they do end up marrying and wanting to start a family, what are they going to do with these fertilized eggs, these frozen embryos? They're probably going to go to the bin in the end. So it's a little bit hard to predict. And I'd say most of the frozen embryos that are fertilized are probably coming from now couples who are choosing to go through this process before starting their family to try to have children later on in age, like later on in their fertility, once they're past their own natural fertility window, to then turn to these frozen embryos so they can have babies at a later stage. And in Israel, you're allowed to use your frozen eggs or embryos up till age 54. So, which is a debate in and of itself. We won't go there today, but that's the upper age limit that women can use their own frozen eggs, or couples could use embryos that they froze previously.
How
so that's
fascinating.
well past any natural fertility window. And personally, I have some issues with that, but I'm not the regulator in the country, so I'm just going within what there is in the law at the moment. I think it will change. I think it will get younger, but fertility treatments with one's own eggs is allowed till age 45. If a couple has fertility problems, they're allowed to have IVF up till age 45. But with frozen eggs or embryos, it's 54. So yeah. It's interesting.
Thank you. That's absolutely fascinating. You really are at the cutting edge, medically, ethically, socially, legislatively. It's really quite incredible. Raelia, I'm really interested in how the Australian scene compares to that. If you could give us an overview, please.
Sure. Well, it's similar here, actually. Currently, practice is more like upper age limit of 52, but similar. I guess the major concerns when you are carrying your baby later in life, that, while carrying a pregnancy when you're in your 20s, for example, you seldom hear of a pregnant woman having a heart attack because she's pregnant, or, having kind of a major risk to her own life because she's pregnant. Whereas later on in life, it is much harder to sustain the physical challenge of pregnancy. So it's one of those things that when we do help a mum to conceive past the natural fertility window, we have to speak to her very candidly about her risks of being pregnant, very high risk of having an operative birth, very high risk of having conditions like blood pressure in pregnancy, preeclampsia in pregnancy, gestational diabetes in pregnancy, mobility concerns in pregnancy, ongoing concerns with things like uterine prolapse and other kind of pelvic instability, just because our bodies find it a bit harder to deal with the constraints and challenges of pregnancy. In terms of the pattern, I agree with Jordana that it's probably a transition situation because of the fact that there's a generation of women to whom the technology of oocyte donation has really not been available historically. So when these same women were in their, say, early 40s, technologies that we use day to day today, like egg freezing, egg donation, they just weren't available to them back then. And so now there's a cohort of women who are in their late 40s, early 50s who avail themselves of that technology at that time. And I think over the years, as technologies become more mainstream, people know about them earlier. The person who has wanted a baby since she was 40 and then kind of adopted the technology at 50 will be able to do it when she's 40, and we won't have the same situation as we do today. So I think there's a bit of a legacy dynamic there as well. At the end of the day, we can have women go through infertility and need a donor egg at any age. A woman might have had, say, a childhood cancer and needed chemo, would need a donor egg, even at a very young age. So it's a miracle that we can assist. And it's a beautiful thing that we do every day in modern medicine.
I think miracle is the operative word. I think you two ladies are working miracles. Yep. You really are. And I feel so honoured to have you here today. I'm going to throw to Halsey Brustman and ask her to thank you both. Please unmute yourself, Halsey.
Halsey, we can't hear.
You need to unmute, please. There you go.
right?
Yep, got you.
Sorry, I leave my alarms at home have gone off, so I'm sorry about that. At first, I want to say to you, Geordie, you were outstanding. I've heard so much about your work, and I know your family, but to hear you today was fantastic, and I learned a lot. And Ray, I've heard so much about you for so long from so many rabbis. They said, what do you mean you haven't heard her? She's internationally famous. So I just want to thank you also. I'm sorry about COVID in your family, and please God, there should be a quick recovery. And Miriam, you were terrific as an MC, and the questions were great. And on behalf of Shari Sedek and the Eden Centre, who are co-sponsors for the visit, the two great girls, Naomi as well, who isn't on this session, I want to thank you sincerely. We can all gain from the knowledge you're doing. And as Miriam said, it is miracle. It's fantastic. And I've left for you, Raelia, with your assistant, a small presentation that you'll look at and say, I remember today as being so fascinating. So thank you so much. And may we all stay healthy and no more COVID.
Amen. Amen.
Thank
Thank you
you.
for the privilege to be here. I think we're all very lucky to be in this line of work, and it's really a pleasure and a privilege to speak today. And I'm glad we managed with Zoom. Who would have
Yes.
thought? But here
Thank
we are,
you.
both
Exactly.
in Melbourne and on Zoom.
I know. No, well, maybe I'll give you a little bit of a virtual tour of the clinic once we finish the session.
Okay, great. Thank
Thanks
you.
again, everyone. Thank you for joining us
Thank you
today.
so much. Bye.
Bye-bye.
Bye.
Bye.